we're just thrilled to have Dr. Hunt here speaking with us about dying with dementia, economic, regulatory, and social forces shaping hospice care today. Dr. Hunt is currently an assistant professor in the Department of Physiological Nursing at UCSF. She's also a senior Atlantic Fellow in the Global Brain Health Initiative, affiliate faculty in the Philip Arley Institute for Health Policy Studies, and co-chair of the Geropsychiatric Nursing Collaborative. She received her BA from Columbia, her MSN at Boston College, and her PhD at UCSF. And she was a VA Quality Scholar at the San Francisco VA Healthcare System. Her research has been funded by the NIH, the National Palliative Care Research Center, the Alzheimer's Association, has focused on understanding geriatric and palliative care needs and experiences of older adults with dementia throughout the care trajectory and across settings. She currently is funded through the Paul Beeson Emerging Leaders Career Development Award in Aging. And that project is funded to examine the impacts of Medicare hospice payment reform on hospice use in older adults with dementia. I am thrilled that Lauren is here. I am very honored that I get to work with her on a project through Mount Sinai and UCSF, where we're looking at hospice as well as other home-based care in dementia as well. So I'm thrilled to have you here, Lauren, joining this group.
Well, thank you so much, Catherine. That is a really wonderful, warm welcome. And I am just so honored to be here presenting with this illustrious group today. I'm going to go ahead and share my screen here. All right, can everybody see that okay? Okay, I'm going to go ahead. Okay, so I'm really excited to be here to talk with you all today about one of my favorite subjects, dying with dementia and hospice care. All right, so my objectives for today, I'm going to start by giving some background on dementia at end of life and how dementia is an increasingly important factor among U.S. decedents. Then I'm going to give some brief background on the Medicare hospice benefit, and I think that a historical understanding will help to contextualize some of the current challenges that we're facing in hospice care for people with dementia today. And then I'm going to discuss how these changing trends in hospice use are specifically impacting people with dementia in hospice. And then I'll launch into talking about how Medicare's regulatory response to some of these concerning trends that we've seen in hospice over the past 20 years, and specifically how this response is impacting people with dementia. And then finally, I'll discuss some solutions to improving hospice and end-of-life care for people with dementia, and would love to open it up to all of you to hear thoughts from the expertise in this crowd. And I'll just say, I'm going to go through some of the slides, and I'm going to pause a couple of times to see if there's any specific questions. And then at the end, I'll open it up for questions and discussion. All right, so I don't think I need to tell this group that dementia is a major public health issue facing the United States today. With the aging of the population, the number of people with dementia is rising rapidly. We're expecting to see almost 15 million people with dementia by the middle of the century. And I think this group is well aware that the costs of caring for people with dementia are enormous, not just in terms of the financial costs, which are estimated to be more than the costs of cancer and heart disease combined, but also in terms of the amount of patient suffering and impacts on patients and families. So I think it's pretty well recognized that dementia is a really critical public health issue but I still think it's under-recognized, the impact that dementia is having at end of life. So dementia is indeed a terminal illness, and it is the only major cause of death where the death rate has been increasing over the past 20 years or so. As you can see from this figure, there's been a really rapid increase in death rates from Alzheimer's disease, in contrast to other major causes of death, such as heart disease and cancer, which we've seen their death rates decline over the same period. So not only is dementia increasingly documented as a cause of death, but it's also increasingly prevalent as a comorbidity at the time of death. So although the cause of death might be something like cancer or heart disease, the person also has dementia as a coexisting condition at the time of death. And this has led to a scenario where it's estimated that almost about 1 in 3 older adults 65 plus are dying with or from dementia. And I think because of the profound impacts on cognition and function that dementia causes, it's really important to consider people who experience dementia as a comorbidity at end of life, even though it's not necessarily the documented cause of death. So there are some characteristics of the dementia trajectory that have really important implications for end of life and hospice care that we're going to be going over later. So the typical conceptualization of dementia is that it's characterized by a slow, long, dwindling decline in function, although the project that Catherine and I are working on, we're looking at the impact of disruptive events that may accelerate the decline in people with dementia. The other feature of dementia that's really critical is that it's really difficult to prognosticate when people with dementia are going to die. So this is data from a study by Susan Mitchell, where they tried to create a prognostic tool to predict 6-month mortality for people with advanced dementia. And basically what they found was that this tool was only slightly better than flipping a coin at predicting 6-month mortality. So our knowledge about the end of life experience for people with dementia is still pretty limited, but we're starting to get a sense of what that experience is like for people with dementia and their caregivers. And what literature is showing is that it's really a very challenging experience for many patients and families. This was a study that was led by Amy Kelly, formerly of Mount Sinai and currently deputy director at NIA. And she examined costs of care for people with dementia and their last 5 years of life. And as you can see in this figure, spending was a third, and this effect was biggest in considering implicit or informal and out-of-pocket costs. So this is a study by Catherine Ornstein, where they looked at caregiving strain in people with and without dementia were at end of life, which they defined as their last year of life. This is a study I love to cite. And you can see in this figure, caregivers of people with dementia experience much greater burden of caregiver strain, and this burden was even higher for caregivers who are caring for people with dementia in the last year of life. So on average, though, we see that people with dementia actually rate their overall quality of care end of life similarly to people without dementia. This was study led by Krista Harrison here at UCSF. And this shows the percent of bereaved caregivers who rated their care excellent in the last month of life. And as you can see, pretty similar for people with and without dementia. I would point out that overall, these ratings are actually not great given the swing effects of this measure. And I think that anecdotally and in qualitative research, we're hearing more challenges that people with dementia and their caregivers are facing at end of life. This is, for example, a quotation from one of the participants in a study I worked on with Jarman Ye here at UCSF, where we asked caregivers of people with dementia about their end of life experiences. This is one person's response. I believe the doctors are checked out. There seems to be no connection between their work and the day-to-day decisions and care that needs to be done for patients with dementia. A more interconnected approach between doctors and their front offices, nurses, hospice workers, lab social workers, and caregivers seems necessary. We all face this. Why is there not a better system in place for patients as they move from one stage to the next? And just indulge me, here's another, I love these quotes. Caregivers should back down and end of life care should be explained. I was not ready. I had no plan. I didn't even know what hospice was, practically speaking. I know the word and its definition, but I didn't know how it worked. I did not know or see a list of things you need to do who was dying at home. I missed the moment of death because I was answering the door for an oxygen delivery. It was absolutely the worst experience of my life. Not my mother's death because she was suffering, but the mental trauma was significant and I still haven't recovered. So now I'm going to shift gears a little bit and give some background on the Medicare hospice benefits. And to understand hospice, we need to go to everybody's favorite decade, the 1980s. Yeah.
Sorry to interrupt
Yes.
you. You're starting to go a little bit in and out with sound. So I'm wondering, I don't know if it's just me on my end, but I'm wondering if maybe if you turn off the video, if that might help a little bit. Sorry that you'd have to do that, but
let's see here.
let me see if I can turn it off.
Okay,
stop
I'm turning off my video.
Yeah,
Hopefully,
and try that and see if that
okay, we'll try that. Sorry about that. I'm not exactly sure.
let me try that and see if that helps. Sorry.
Okay. Okay, so me again if it's not working. I just restarted my computer, so hopefully it's not bad.
Okay. sounds better right now.
Okay.
So,
okay. So yeah, everybody's favorite decade in the 1980s. So hospice really started as a social movement in the late 70s and 80s, and it was led by Florence Wald and other oncology nurses who were disenchanted by a medical model that emphasized disease treatment at all costs. So there were some early demonstration projects in the 1980s for cancer patients, which showed improved pain and symptom management and reduced costs. But these early studies showed that the cost of care in hospice was very sensitive to length of stay. And so at a time when the Medicare hospice benefit legislation was being written, this was a time in US history when there was really a lot of concerns about healthcare spending. And so a central concern at the time is that hospice should not increase cost to Medicare. So as the hospice legislation was being written, there were a number of measures that were put into place to try to ensure budget neutrality. These included a prospective per diem reimbursement model, limiting eligibility criteria to people who had expected prognosis of less than 6 months. Enrollees had to forego traditional medical services. Nursing home residents were not eligible for the hospice benefit. And the total number of days that somebody could be enrolled in hospice was limited to 210. And then finally, there was this an aggregate cap was placed on which set average amount the hospices could receive per patient at a capped amount. And this was essentially going to limit long lengths of stay in hospice. So in 1986, there was hospice legislation that revisited of these initial statements, and there was concern that excluding nursing home residents deprive nursing home residents of potentially beneficial end-of-life symptom management care. They also recognize that prognostication is often difficult and that cutting people off at 200 days also potentially deprive people of beneficial services. So they got rid of these eligibility criteria. And what we saw afterwards was explosive growth in hospice that really continues to this day. So there was big increase in the number of hospice providers. There was a shift from hospices from nonprofit to large for-profit, corporately owned chain hospices. And for hospices that are really interested in maximizing their profit margins, the most effective business model to achieving this is to try to enroll long stay, low need, and low cost patients, such as people with dementia. So in this figure, you can see the growth in number of hospice providers from the year 2000 to 2020, and the number of hospices has more than doubled, and this you see big increase in for-profit hospices. There's also been a rapid increase in hospice expenditures during that time, from about $2 billion per year in 2000 to almost over $20 billion in 2020. Another trend that we've been seeing recently is the entry of private equity into the hospice market. This is a study done by Braun et al., published in JAMA IM, which showed the number of Medicare hospice beneficiaries who receive care from a hospice owned by a private equity firm. And people are really concerned about private equity moving into hospice because private equity is an investment model that is very focused on turning around big profits in a short period of time. And this raises concerns about quality of care. It creates a lot of cognitive dissonance for people when you're talking about dying parents and grandparents. Some of you may have seen this New Yorker article that came out back in December that delved into some of these concerns that have arisen over the hospice industry in the last several decades, and looks at some of these issues around Medicare fraud, poor quality of care for patients, and has some pretty compelling stories about the experiences from hospice whistleblowers and hospice patients. So I'm going to stop there for a moment and just see if anybody has any questions. Yeah, I see somebody with their hand raised.
Yep.
And also, I just want to check in that the connection is better.
It's better. Yeah, it goes in and out a little bit sometimes, but it's better than before. So
okay.
Hopefully that helps. Yeah.
Yeah.
Hi, I'm Sharon Hall, and I always am the young onset advocate here everywhere I go. And there are young people, and we have a tremendous amount of difficulty with hospice, especially with FTD, which does not look like Alzheimer's. Are you going to address some of those differences that should happen in hospice?
Yeah, so that's a question. I don't talk about it specifically in this talk, but I think that it's a really important issue and something that we're thinking about here. And those of us working on these issues is, yeah, because I do think that there are really important differences depending on the subtype of dementia, not only early onset, but also, FTD and Lewy body and Parkinson's, and those people have very different trajectories based on the type of dementia. And I think that right now in hospice, in my experience working as a hospice nurse, I just think that there's very little knowledge out there about how to tailor services to the different needs of patients, different
Yes,
types of dementia and their caregivers.
Unfortunately, a lot of people with FTD are put on hospice a week before they die because they don't meet the requirements. But they're well on their way to death, and it's a huge problem among that population, and that population is growing 200%. So
no, absolutely agree. Yeah, and I think actually I'm going to be talking with a fellow later this week because she's her research is focused on Parkinson's, and like we really know like absolutely nothing about Parkinson's, and the medications are completely different. And there's we use antipsychotics a lot in hospice, and the medications are really contraindicated in those subtypes. And I think there's a lot of room for growth in the hospice industry and amongst clinicians about how to best care for the heterogeneity going on there. So
as a young onset advocate, I always advocate for palliative care, because usually if someone can have palliative care, they can see the progress of FTD, and those people tend to get hospice when they need it. But more education needs to be done in hospice about other dementias, I must say.
Yeah. Yes. Thank you for raising that point. Appreciate it. So somebody else has their hand raised.
Yeah. So thank you. This is interesting. And I didn't actually understand the hospice benefits. So this is something fun for me to learn about. And so, and then the equity piece is really fascinating to me. So like, I guess just in general, is that, so one question is about the previous slide where you talked about the percentage. Does that mean that there's basically 16% of hospice care or beneficiaries, hospice Medicare beneficiaries are receiving hospice care in a for-profit facility? Is that kind of how I would interpret that?
Yeah. So basically the way it works is that amongst hospice providers, like organizations, about 75% of them are for-profit. And that means that that translates into about 50% of patients receiving care from a for-profit hospice.
That's great.
Yeah.
The other quick question is just like for prevalence, like for patients, bringing it back to Alzheimer's and dementia, like, is there any sense of what percentage of patients in hospice also have an accompanying diagnosis of Alzheimer's and dementia?
Yeah. Okay. So that's a great segue because I'm going to be talking about that next. Okay. So now I'm going to be shifting to talking more specifically about hospice for people with dementia. Okay. So I've been talking about how dementia is more prevalent at end of life. There is more uncertainty around prognosis. People can look like they might be hospice eligible, but then live for a long time. There's been big growth in hospice use, providers, and expenditures, and concerns around potentially concerning or even fraudulent behaviors and profiting off of patients who tend to have long stays in hospice given the reimbursement mechanisms. So not surprisingly, what we see is a big increase in the number of patients with dementia in hospice over the past 20 years. This is from some work I did with Melissa Aldridge at Mount Sinai, and also another study led by Krista Harrison, where we looked at people admitted to hospice for dementia, as well as those admitted for another terminal condition, but who had coexisting dementia diagnosis. And basically what we found is that, well, first of all, there's been a really big increase in number of patients with dementia over the past 20 years. And we found that about 20% of hospice enrollees are admitted for a terminal condition. Their qualifying condition is dementia diagnosis. And another 25% of them are admitted for another terminal condition, but have a coexisting dementia. So what this means is that about half of all hospice recipients have dementia. So this is a really important population that we need to be thinking about in hospice. So in these studies, we found that the hospice use patterns look really different for people with and without dementia. So both people with a primary and comorbid diagnosis of dementia are more likely to have long lengths of stay in hospice, to be enrolled for more than 6 months. And this slightly is higher for people with primary diagnosis compared to comorbid diagnosis. They're also less likely to have very short stays in hospice, so being enrolled for less than 3 days. We also found that people with dementia are more likely to be disenrolled from hospice. This is also called live discharge sometimes. So almost 1 in 4 people with dementia are discharged from hospice alive. And then this is much more common after long lengths of stay for people with dementia compared to those without dementia. And when people are disenrolled after long stays, it's usually because the person no longer meets prognostic eligibility criteria. So in the beginning, I talked about how in order to be eligible for hospice, you need a likely prognosis of less than 6 months, but you can then continue to be recertified as long as you're showing evidence of decline. So if people stabilize or the condition improves slightly, then they're at risk for being disenrolled. So sometimes people refer to live discharge as graduating, but I like to call it getting expelled. I wrote an editorial in JAGS with this title because the research shows that disenrollment is really a bad experience for patients. It disrupts their care continuity and the relationships that people have developed with their hospice providers. And there's really very few other services available that offer the similar level of comprehensive and holistic care that the hospice does. This is a quote from a family caregiver who is getting discharged alive. So as of tomorrow, no CNA, no medical equipment, no medicines, no nurses checking him out. We have to re-engage with all his physicians, go to their offices, get them reacquainted with his new symptoms, get new prescriptions for meds, obtain new durable medical equipment, and fight for insurance coverage. So I saw live discharge as being a really big issue amongst the patients that I was caring for when I was a hospice nurse, and really wanted to delve into this issue more. So we conducted a study looking at provider and geographic variation in disenrollment for people with dementia. What we found is there was really a lot of provider variation in disenrollment. So basically, where a person receives hospice from doubled their likelihood of disenrollment on average, regardless of any of their patient characteristics. We also found a lot of geographic variation, mostly in patient-initiated disenrollment in these particular hotspots in Southern California and the Southeast, where some of these biggest concerns about hospice fraud have really been centered. Okay, so now I'm going to move into talking about Medicare's regulatory response to these concerns in hospice and talk about some of the effects of these policy levers on hospice care for people with dementia. I think Joanne has her hand raised.
So
Jennifer, it's like Jennifer.
yeah,
Sorry, Jennifer.
yeah, no, I just go back one slide.
Sure.
I think that this is really fascinating, as was the summary of what's happening with for-profit agencies and venture capital. And I was just curious, do you know anything about whether some of those trends are more geographically based in terms of where the agencies are located?
That's actually a really good question. I have not personally looked at that, and I do not know if anybody else has looked at that. And that is a really fantastic research question. So maybe I'll go do that.
I asked Melissa Aldrich about the same question, particularly around private equity. And particularly thinking around neighborhood context, and are they disproportionately going into certain neighborhoods? And she said that it was challenging to get that data from the private equity hospice agencies, etc. But that's something that she's thinking about.
Yeah, I'm working on a project with her where we're trying to look at private equity takeovers, and we're kind of in the weeds of it right now. It's pretty challenging to figure out. Actually, you have to get these industry data sets and then link them to the Medicare data sets, and there's just there's a real lack of transparency around what's going on, which is another big issue. So, and also the other thing about private equity is that, when I showed in the brown paper, a lot of the increase has been in the last few years and really, and I would say in the last 5 years. And so we have a bit of a data delay because, most of our data only goes up through 2021, and then you have to have a couple of years of data after that to really be able to see impacts. But I think that this is going to be a real emerging issue. So yeah, and I think understanding the geographic variation and how these markets work is something that I'm thinking about a lot, and also in the context of thinking about racial disparities as well, whether these are centered in areas where there's higher proportion of minoritized populations.
Can I have a question? This is very exciting. Do you observe any type of anti-competitive behavior in the industry, in particular among private equity firms? Recent wave of horizontal merger.
One of the
prices or anything like that.
Yeah, so one of the things
policy can have an effect.
Yeah, one of the things that Medicare is very concerned about right now is kickbacks. There's going to be a big audit from the OIG, the Office of Inspector General, this coming year. They're certain that hospices are providing kickbacks to nursing homes and assisted living facilities in exchange for referrals for hospice patients.
But anything related to merger and acquisitions, or that raise the issue of anti-competitive behavior?
Yeah, that's a very good question about whether there's like monopolies. Yeah, that's a great question. I think that's another thing that I'll have to investigate further. Yeah, I mean, the industry, I'd say, is still fairly competitive. There's just like a lot of hospices out there, and there's a lot of these I think the concern is more around the entry of new hospices and small hospices, and everybody kind of all like these mom and pop shops, just like trying to make a buck, rather than concerns at this point around monopolies. But this could change. There's been a lot of mergers and acquisitions going on over the past few years, and so that'll be interesting to see how that plays out in the coming years.
Thanks.
These are great questions. I love questions. It helps me. It really helps me to think about what's important.
Ruth Vick also had a question in the chat earlier, which
Okay.
Catherine answered. I didn't know if you wanted to maybe.
Oh yeah, okay. I can't see I'm not looking at the chat. So
no worries. I can read it. Because how often do patients with dementia receive palliative care, outpatient versus inpatient, and is that known?
Oh, how many of them access palliative care?
Patient first.
Yeah, that's another good question. I don't actually know if we know the answer to that question at this point. I mean, I think in terms of, I think access to palliative care has been growing over the past decade or so. And I think Catherine is looking at this in one of her projects. But it's still, I think that there's pockets of the country where there's pretty good accessibility to home-based palliative care. But I think a lot of areas, there's still really limited access, and there's not a great payment mechanism at this point, at least for home-based palliative care. It's pretty robust in the hospital setting for inpatient palliative care. But that's certainly an important aspect of care for patients with dementia, although I would say that, home-based and outpatient palliative care is probably more relevant for this population. So yeah, Catherine, maybe you and I can think about that. And if you want to comment.
Yeah, no, I think that's great, Laura. And I just sort of added that, like, we kind of know there's not enough, and there's really issues around access in general. Right. And there's sort of just prognostic issues of who ends up getting it. So often we see in cancer just because we can sort of prognosticate better potentially, or symptom management. But also there's actually just research, like there's challenges if you're just looking at claims data, looking at palliative care that people are working on, just because often we have providers who are certified in different kinds of things. They don't necessarily bill as a palliative care provider, and they're providing palliative care, things like that. So it's challenging to really see this. But I imagine we're not seeing less of it in dementia for many of the reasons you've alluded to already. So hospice is a lot easier to study.
Yeah, it's easier to study hospice because the data is pretty good, or sort of good. So yeah, but I mean, I do think that, palliative care is going to be, as a model of care, is going to be growing substantially in the next 5 to 10 years. And so I think it's going to be important to think about how that can impact care of people with dementia. And I have a kind of a question about that at the end. Okay, so moving on to talk about Medicare's response. So Medicare has implemented a number of policies over the past decade or so that were really designed to address some of these concerns around long lengths of stay and questionable and potentially even fraudulent enrollment of people into hospice who were not really actually terminally ill. So in 2012, they implemented a requirement that a physician or nurse practitioner make a face-to-face visit prior to recertification after 6 months. In 2013, they eliminated failure to thrive code as a qualifying hospice condition. In 2014, as part of the Impact Act, they increased audits on hospices that had disproportionate number of long stays. And then in 2016, they implemented hospice payment reform, which was the first change to hospice reimbursement model since its inception in the early 80s. And what payment reform did was create a 2-tiered model for payments. So it increased payments for the first 60 days a person was on hospice, and also added a bonus for the last week of life, and then reduced payments for the time in between that. And then also during this period of time, there was the growth of the hospice quality reporting program and mandated data collection on quality, and then finally public quality reporting of hospice quality began in 2018. And then just recently they moved to a star rating system. So there have been a couple of papers that have come out recently that have evaluated the impacts of some of these reforms that were intended to target long stays, and specifically looked at how they impacted people with dementia, who are, as I've talked about, most likely to have long stays. So in this paper, they looked at new enrollments of people with Alzheimer's disease and related dementias before and after the implementation of Impact Act and payment reform. And you can see is there was a big jump in admissions for ADRD after the failure to thrive code was eliminated, and it's basically just code shifting. And then we see that the proportion of new hospice, new enrollees with dementia decreased after the Impact Act was passed, but then started going up again after that, and has kind of been on a slow increase since 2016. Another study from this group found that length of stay was also continuing to increase after these reforms went into effect. And you see this increase in length of stay for people with dementia, and really no increase in people who have cancer. And then finally, we see that disenrollment was already decreasing prior to these policy reforms, probably as people were raising concerns about how disenrollment reduced quality of care for patients. And then after these policy changes, they have pretty much plateaued and at a pretty high rate for people with dementia at around 18%. And so I think what these papers raise concerns about is whether Medicare is just playing a game of whack-a-mole with these hospice policies, where they come up with a policy to try to crack down on some of these bad players and bad practices, and then hospices continue to figure out ways to game the system. This is some work that we've been doing recently. We're kind of trying to replicate those studies that I just showed you, and looking at length of stay for people with dementia versus cancer. And one of the things that we've noticed as we've been doing these descriptive analyses is this pretty stark cyclical pattern in length of stay and also in disenrollment. And we're in the process now of trying to figure out whether this is somehow related to the aggregate cap, which I talked about in the beginning of the talk, which really puts a cap on length of stay, and which previous studies have shown that there's a tendency for hospices to disenroll patients as they get closer to the cap. So right now we're trying to figure out how to disentangle this and see if there's potentially another explanation for what's going on, like seasonal variation and death rates. So I think there's another number of continuing reforms and areas that Medicare is focusing in that are going to be influencing hospice care in the coming years, and some of them we've touched upon already. There's the Medicare Part C carve-in, which I think is going to be really important. So previously for Medicare Part C enrollees, if they elected hospice, they had to, it was basically carved out of their Part C benefits. And now there's a demonstration project going on where the hospice care will be carved into the Part C benefits. This could have, this means that the Part C organizations will have more discretion around negotiating with the hospice providers and potentially offering a different mix of services for hospice and palliative care, which could potentially benefit people with dementia because of their uncertain prognosis. But on the other hand, there, the Medicare Part C is a whole other talk, but there's been big increase in Part C usage over the past few decades, and there's also a lot of concerns around the quality of these Medicare Part C plans. There's been a concurrent care demonstration project that just wrapped up, which allowed for concurrent curative treatments along with hospice care. And I think that this is more relevant to patients with cancer, but may help to expand access to people who are more reluctant to forgo curative treatments. There's a growing emphasis on racial equity in hospice, and there was a recent RFI for information about how to improve equity in hospice, given really well-documented disparities in both access and quality. States are starting to enter the game of regulation. It's been in California, the governor recently renewed a moratorium on new hospices being created. So there was just this really rapid proliferation of new hospices. At one point, there was like 1,000 hospices in the LA area, and these concerns about fraud have really been centered in Southern California. As I mentioned before, the Office of Inspector General is going to be launching a big audit in 2023, and we'll be focusing on hospices that have high proportion of nursing people referred directly from the nursing home or assisted living, given concerns around kickbacks to nursing homes and assisted living in exchange for referrals. And then every year MedPAC puts out a report, or at least for the last few years, and they've recommended reducing the aggregate cap. And so far, Congress has not acted on that, but we'll see what happens in the coming years. And so these are the things, we have a lot of debate in our group here, thinking about what is the role of hospice for people with dementia. And I'd love to just open it up for discussion at this point in our last few minutes. Should hospice really be a benefit that's limited for the last weeks and months of life, and that we should be focusing on developing other models to support people with dementia across the trajectory of decline? Or on the other hand, maybe we should modify hospice, change the payment structures to better suit the dementia trajectory. Hospice is a model of care that already exists, delivers interdisciplinary palliative care across care settings. There's extensive infrastructure already set up. So maybe we can just capitalize on that. We're also thinking about whether Medicare's concerns around hospice costs might be a bit overzealous. So although there's been a real rapid increase in hospice spending in the past 20 years, hospice still is only, expenditures are just over 20 billion. And I'll just point out that, Elon Musk, we were talking about Twitter right before people came on, Elon Musk bought Twitter for $44 billion. So it's really still a relatively small amount compared to other healthcare and other things that we spend money on in this country. So those are the things that I'm thinking about a lot. And I just really would like to, I have the most amazing team of collaborators and mentors and students at this point. And I feel truly lucky to get to work with these individuals, and then also acknowledge my funding sources. So I'm going to stop sharing.
So Lauren, I just was monitoring the chat, and there was an earlier question that you commented on a bit, but maybe you could just revisit this with your final thoughts, just about, hospice as originally designed for cancer patients, and really thinking more about, sort of the getting kicked out or expelled, as you called it, from hospice, for people with cancer versus dementia, and sort of where you see that going.
So I mean, I think, so it's interesting because so disenrollment rates are lower for patients with cancer because I think that it's much easier to determine when somebody with cancer what their prognosis is going to be once you stop treatment. There is still issues around disenrollment for patients with cancer. Patients with cancer are more likely to revoke hospice or patient-initiated disenrollment. And this is, I think, one of the other concerns around the hospice benefit is that you have to forego curative treatments. And so for patients who are more reluctant to forego curative treatments, they will might be more likely to revoke if they decide they want to go back to pursuing those treatments. Also, if they're not receiving appropriate supports from hospice agency, one thing that happens is that patients will go to the hospital in a crisis and then revoke from hospice so that they can get the supports and symptom control that they need. So yeah, I mean, and then I think in terms of disenrollment for patients with dementia, I mean, I think it's pretty interesting that we're seeing kind of a stabilization in the disenrollment rate over the past few years. And one of the things I just started looking at is whether we're seeing changes in the reason for disenrollment and length of stay prior to disenrollment. Yeah, because I mean, I guess like ideally I would say patients really wouldn't, it'd be a pretty rare occurrence that patients would be disenrolled from hospice. And so figuring out the right timing for them and getting systems in place so that patients don't have to experience a disenrollment is something that we should be thinking about how we can do that.
I think Sharon had a question.
Of course, always. I think the answer really is that palliative care. I always encourage the young onset to get it from diagnosis, and that palliative care can kind of carry people into hospice when they really need hospice, especially in the young onset crowd where the Alzheimer's does not pertain to them. It does give them some relief. Young onset costs twice as much as Alzheimer's because of the lack of income in their primary income earning years. So the cost is twice that of Alzheimer's. So there's a tremendous cost issue involved in young onset. And I think that's where palliative care comes in, and it has helped my young onset community tremendously and helps them get into hospice at an appropriate, at a good time in, when they can have hospice services. So it matters tremendously there. There also is an international neuropalliative care society now, and the neuropalliative is increasing, and that's a wonderful way for dementia. They understand dementia, that's all neuropalliative. So that to me is another way of bridging that gap between, when they need it, when they're in hospice, what they need, because we just need the support, whether it be hospice or palliative. I mean, they need the support.
Yeah, I mean, I think that could be a really valuable path forward if we can really develop, home-based palliative care models and then have a kind of really integrated and coordinated transfers from palliative care into hospice care. I think, just thinking about how I think there's still a lot of issues with access, as we talked about, and also, figuring out how do you pay for that. Yeah, and then also if you have that system in place, if a patient did need to be disenrolled, you could potentially be disenrolled back into the palliative care, and then you could have a continuation of the continuity, and then maybe these transitions from being in hospice to not being in hospice wouldn't be quite so abrupt. So Somebody else has Meryl.
Yes, thank you, Lauren, for your report. And Sharon, I totally agree with your comments. I had 2 experiences with hospice at home. My husband was early onset. He was kicked out 3 times, each time reviewed. They measured active dying by checking the circumference of his arm with a tape measure. Which is probably the most insulting thing that has ever happened over and over again. And what they didn't understand, and it's very hard for me to see how they retrofit dementia care at the end for palliative care in using the cancer model. Because what happens is they get kicked out because they passed the 6-month mark. The doctors, they qualify, continue to qualify, yet they're kicked out because of that 6-month window. Then they're brought back into the system. It happened 3 times for my husband, even at the very end. At the very end, he outlived their projections. And trust me, I had that with my mother as well. It is the most insulting and painful period in that dementia journey. And I was there for 24 years on that journey. So I really think we need an alternative method because the doctors don't know. They have an episode, they qualify for hospice, they sink deeper, and then they plateau. And it's in that plateau that they're trapped in that hospice mode. And it happens progressively. So it really needs to be rethought for families. But thank you for your work.
I mean, when I hear stories like that, it's really, it's what keeps me going, because I just think it is just so traumatic for patients and families to undergo these experiences. And I see that, Cynthia, also this happened to your mom, and it just creates a lot of churn and just makes it what it's already such a difficult experience even more difficult for patients and families. So I think, I mean, I will say also that people are trying to figure out how to prognosticate better for people with dementia. This team here, the Alex Smith and Saley are working on their predictive models to try to get a better estimates for 6-month and 1-year prognostication. And so that's one piece of the puzzle. And then I think also thinking about how we can modify hospice or develop other care models, or really thinking about regulation and cracking down on these bad players who are taking advantage of patients and families.
I think we're out of time. I want to join everyone in thanking Dr. Hunt for this incredibly informative, wonderful presentation. And there are still some questions and ideas and suggestions, so I hope it's okay if folks contact you directly.
Yeah,
Lauren.
absolutely. Please do.
This has really been really exciting. So thank you.
Yeah, it was really my pleasure, and just so great to see this amazing group. And thanks for your participation and engagement. And thank you so much.